Well, welcome. This is part two of our talk on refractory or difficult to treat chronic headaches. I'm Dr. Larry Robbins of the Robbins Headache Clinic in Riverwoods, Illinois. This is our YouTube channel. I started the section of the Headache Society, the American Headache Society, called the Refractory Headache Patient or Difficult to Treat Headaches. And in part one, we talked mostly about non-medicine aspects of headaches, what to do um, as far as outside of medication or pharmacologic approaches. We talked about what causes the headaches. We talked about medication overuse headache versus medication overuse. And in part two now, I'm going to talk about a couple subjects, but mostly treatment. 5 solid outpatient treatment options that sometimes we use, and then miscellaneous options for when nothing works. First, a little bit about acceptance and coping. We're always trying to promote acceptance of a chronic illness, whether it's headaches or chronic pain or diabetes, etc. The lack of acceptance leads to people going to many different clinics. I always say the road to acceptance is littered with stop-offs at many alternative practices looking for a magic cure. People look for a magic cure that might be an aha moment, which we rarely find in chronic headaches. The aha moment people are looking for, sometimes they have fillings taken out of their teeth, the mercury fillings or implants taken out. Sometimes they'll get on medication for chronic yeast infections, which never seems to help, or chronic Lyme disease, which is very rare, or viruses like Epstein-Barr. Everything has gone through its iteration and its time. In the 1980s, we have chronic yeast infections, which were supposed to cause headaches, and then it turned out nobody had that. And then it became chronic Epstein-Barr or virus infections, and that came and went. And then it became Lyme disease. And now what I see is things coming back. I've seen several people in the last couple of weeks on medication for chronic yeast, which was debunked 20 years ago, but it seems that that's back. So acceptance is very important. Sometimes we have what I call lack of acceptance by proxy, where people don't accept that their kid or their spouse can have headaches. I hear people say, how can a 16-year-old possibly have daily headaches? Well, it's very common. Millions of 16-year-old and adolescents have had daily headaches. So we try to promote acceptance and teach that we can't cure the headaches or the chronic pain, but we can manage them along. As far as coping, we try to promote active coping versus passive coping. If you look at what defines disability or what risk factors for people becoming disabled, passive coping is a major risk factor for disability. Passive coping means when somebody says, Dr. Robbins, when you give me enough drugs and enough painkillers, I'll get out of bed and work. And that doesn't work. That's passive. Active coping is working, volunteering, getting out of the house, physical therapy, exercise, everything except sitting around watching TV and taking too many drugs. Now, a bit about caretakers. When people do have a spouse or a kid or a mom with severe pain or severe headaches, it takes its toll. They're a caretaker of somebody who's ill physically, and that's a problem. I think that it would be helpful to have support groups for caretakers. It would be very helpful to have books on what caretakers for severe pain patients can expect, because it's a big issue, and we see a lot of depression, a lot of anxiety. There's been studies that caretakers of people, mostly say a parent with Alzheimer's or a spouse, have a very low quality of life and high depression ratings. Also, headache doctors and headache nurses who see people with chronic pain have very high burnout rates. About 50% of 58% actually of headache patients or doctors in one study felt that they were burned out. And this isn't good for patients. It's not good for the doctors. The doctors end up quitting. They're not very sympathetic. So we do a lot in our clinic, and I think I teach a lot in my lectures to doctors how to try to avoid burnout. Now, moving on to where we go with outpatient therapy options when nothing is working, which is common. I think that 40 to 50% of people with chronic headaches, the usual treatments don't work very well. Hopefully, we'll have better treatments in 5 years. There's no great algorithm. It's not like a good decision tree is easy with chronic pain or headaches. Unlike diabetes or high blood pressure, where we have better algorithms, everybody's different. There's a lot of factors that go into our treatment decision tree where we go with medicine. Now, I've identified actually about 50 factors that I'm working on, and we'll post this in another lecture fairly soon. But the medication history, the headache history, family history, medication problems that people have had, if they had side effects to medicines, this all goes into where we go. Also, psychological conditions that may go along with the headaches, medical conditions. If somebody has anxiety or depression, we're going to treat that person a little differently and with slightly different medicine. Sleep issues come into play quite a bit, insomnia, etc. Do they have sleep apnea? Also, stomach issues. GI issues are common. Stomach with headache patients. A lot of people have irritable bowel syndrome, IBS. And if they have constipation, we'll use one set of medicines. Diarrhea more, we'll use another set of medicines. People's energy level. If you ask people with chronic headaches what your biggest problem outside of headaches is, it's tiredness. I'm tired. They say, I wake up tired, I'm tired all the time, I have no motivation, no energy. So in people with low energy, we don't want to tack on medicine that decreases energy, that makes them more tired. So these and a number of other factors add in. Financial too. We don't want to say, well, let's do Botox for your headaches if we know people can't afford it. We don't want to prescribe medicine that we know people cannot afford. So financial issues and also social, how active people are, their job, an accountant or a physicist or a chemistry teacher in certain times of the year particularly. We don't want to give medicine that are going to make them spacey. Topiramate or Topamax is the typical headache medicine that makes people spacey. So all of these factors and others come into play when we decide what's the top 10 list for this person versus that person. Now, one of the treatments that I mentioned is Botox. It's actually very, very safe. We've been using it for 20 years. About 9 million people, I guesstimate, have had it worldwide for headaches. It's not new. It's the only medication, the only treatment that's FDA indicated for chronic migraine, chronic headaches. So Botox should probably be used first line or quickly, but because of the cost and its injections, we tend to use other things first. In fact, most people have tried 3 or 4 preventives or 6 or 8 preventives like amitriptyline and Depakote and Topamax before they move on to Botox. Recently, there's been some studies indicating that chronic use of Botox leads to less and less headaches where people revert from chronic, at least 15 days a month of headaches, to episodic. And then if you stop the Botox, the headaches stay good. So it's been a nice side effect of Botox that we have long-term much less headaches. Botox tends to be expensive, but that's about the main downside. And many people's insurance, they do receive the vials over to the doctor. It doesn't hurt that much. The Botox itself is not stingy like the Novocaine for the dentist, which hurts a lot more. So it's really how we do it is different in every patient. There's the FDA protocol for Botox, which is 31 shots all around the head. It's a lot of injections. I tend to do less. We tend to do 10 to 14 injections and a lower dose. But everybody does, many people, doctors will do Botox a little bit differently. Another option with Botox is off-label use for cluster headache or for facial pain. And I think it works better in migraine. It's been studied in all of these conditions, but it's only FDA indicated officially in migraine, which is important for insurance, trying to get it paid for. The mechanism of why Botox works is iffy. I think it probably works through the immune system. It dampens down the neuroimmune system. Back in 1987, I was convinced that the immune system was a key in headaches, and we did studies. We looked at helper and suppressor cells, we looked at NK killer cells, and it turns out the immune system is overactive in people with headaches, probably in other conditions that we didn't think about, like depression also. They think that inflammation and the neuroimmune system is crucial or helpful causes more depression also. So Botox in the end works on this compound called CGRP, and a number of companies are working on shots that decrease CGRP, and that may be why Botox in the end works. It never made sense that just relaxing muscles, which is part of what Botox does, really is the mechanism of why it works, and I think it's probably more immune-based. Now, one other option that we go with treating the headaches, the second, is polypharmacy, which is using more than one medicine at the same time, preventive. So a lot of people take Botox, they're also on Topamax, and they may be on a mild blood pressure medicine for their headaches as well. So polypharmacy, we call it rational polypharmacy, things that fit well together or for that person's comorbidities. If somebody has high blood pressure, we'll use something for that. If they have anxiety or depression, we'll use an antidepressant. If they have stomach issues, we'll avoid medicines that hurt the stomach. So we try to use medicines that fit together, that fit that patient's profile. One other option that we use more in the last year or so, but it's been around a long time, is SPG blocks. The SPG is a collection of nerves in the cheek. And in fact, one company is working on an implant into there with a neurotransmitter that you can stimulate and stop the headache. So they put in the implant. It's in experimental stage here for cluster headaches in the United States, but it's been in Europe for 5 years and fairly successful. So the SPG is this collection of nerves that people have blocked with Novocaine type medicine for over 100 years. Even in 1914, when it started, they were using cocaine, I believe, and later on other canes like lidocaine, and we use Marcaine. But we squirt this up the nose, and it used to take an hour or so. It was a very difficult procedure, not that accurate. Now there's several devices that make it easier to block the SPG right up the nose. It takes 10 seconds, and people do this once a week or so. We've identified some people with chronic migraine where nothing worked, where this approach works. So SPG blocks are a possibility. And in the back of the head, that helps the front of the head. In the back of the head, we'll do occipital blocks or nerve blocks where you have to use an injection and it does hurt in the back of the head, or what we call trigger point injections where we go where the tenderness is. There's two big nerves in the back of the head, the occipital nerves, and we'll block those with Novocaine. Sometimes we do that in the back of the head, and we'll do the SPG blocks in the front of the head. One other option that people sometimes lapse into are daily triptans or frequent triptans, like there's 7 of them out: sumatriptan, rizatriptan, Axert is now generic. A number that were trade names and branded 6 months ago become generic. There's only a few branded ones left, such as Relpax or Trexamet. And many people notice that their preventives don't work. The only thing that works is a triptan. And the good news is triptans have been out for about 25 years. At least 300 million people have had them. I think this huge body of evidence points towards their safety. There's been relatively few serious side effects. With advancing age and increased risk factors for heart, such as diabetes, high cholesterol, high blood pressure that's not well controlled, we'll be careful with the triptans. But even in some high-risk patients, they've done reasonably well, but we try other things first. But the triptans are not as safe as taking nothing, but I think that they're probably safer, even if used on a frequent basis, than many of the medications that people take. NSAIDs, for instance, ibuprofen, naproxen, which is over-the-counter, as Aleve, ibuprofen is Advil or Motrin. The NSAIDs, prescription and over-the-counter, really cause over 90% of our serious side effects. Bleeding out of the stomach. Last year, over 60,000 people actually died because of NSAID use, either kidney failure or bleeding out of the stomach from ulcers. So it's very common to have side effects from those. The triptans, on the other hand, sumatriptan, rizatriptan, bromotriptan, naratriptan, they're all a little bit different, and some people notice they're the only medication that works. So I think that in refractory, difficult to treat patients, using these frequently is an option. It's not as if we prescribe them that way, it's just people lapse into it, and I've been noticing since the 1990s, some people are off their preventives and notice the only thing that works is a triptan. So when we do frequent triptans, we will do monitoring. I did a couple studies a number of years ago where we did echoes of the heart and EKGs, and they were fairly safe. But it's not as if we give these to people and say, come back in 2 years. People do need to be monitored with their doctor. One other option that's been controversial is long-acting opioids. Painkillers and opioids used to be used quite often, and then they tended to be overused a little bit or a lot of it, and there's been a number of overdoses and deaths from opioids, so the use is cut back. But I think that the pendulum has swung too much the other way against the use of painkillers, because often the other medications don't work and the preventives don't work. Most of our overdoses now, people have shifted over to heroin, unfortunately, and they're overdosing on that. We used to say it's not about the drug, it's about the person. And it's not this specific drug or that specific drug. If the person has addictive tendencies, if they have psychological problems that tend towards addiction, they're going to overuse whatever they can. So they may shift, and we've seen that shifting from the painkillers, which are difficult to obtain and expensive, over to heroin, which is cheaper and easier to get. So in that sense, it is the person and not the drug. It's controversial whether to use opioids in headache patients. Many doctors feel you shouldn't use them at all. I think that with careful patient selection, there's a small minority of people who do well long-acting, long-term with opioids. We've had some people for 20 years now on the same low dose of opioids where nothing worked, and every time they go off the opioids, their headaches are pretty severe. We always try to get people off of these medications. So there are concerns with these: addiction, overdose, creating more headaches. So I have certain rules for long-acting opioids, who to go on, and it narrows the field down to not that many patients, but there is a small minority. My rules for success with opioids: people have had to have done well with short-acting opioids, such as short-acting hydrocodone or codeine or tramadol, before we use long-acting ones. People need to be older than age 28. I don't want to use these in younger people, and we certainly don't want to start them in somebody who has not had frequent opioids. We don't want to sensitize the brain and get them used to them. We try to avoid personality disorders, particularly borderline personality and antisocial personality. People with severe personality disorders or moderate to severe are much higher risk for overusing opioids and overdosing. People have to have a non-addictive personality and not have had problems with addiction in the past, and that's very important. Some people have said cigarette smoking is actually a predictor of whether somebody is going to become addicted. Now, there are some exceptions to these rules. If somebody in the past had addiction to alcohol and they've been clean and sober for 10 or 15 years, they may well not overuse the opioids. But I think that in general, we try to avoid people who've had addiction problems in the past. People really have had to have done well on the opioids, though, without accelerating the dose. And that's what kicks most people out of this category. Many people go on 1 pill a day or 2 pills a day, and within 2 months they need 4 or 6. The ideal person for opioids doesn't have a personality disorder, did well on short-acting ones, is older than age 28 or 30, but does not become what we call tolerant to the analgesic pain properties of medicine. Now, tolerance is different than addiction. People confuse these all the time. many people say, I think I'm addicted to Ambien, or I'm addicted to Xanax, or I'm addicted to Vicodin, when they're taking 1 or 2 a day, and that's it, and they don't keep accelerating the dose. Tolerance is where you're used to a medicine and you go through some withdrawal if you don't have it, and that's expected from all of these medicines. That's okay. Tolerance is okay. Addiction is not. Addiction is a set of behaviors that crosses the line. Calling the doctor's office with phony stories, going to 3 or 4 or 5 doctors, calling the office saying that my dog ate the prescription for Vicodin, it fell into the toilet, I left it in a hotel room. Now, once a year, one of these stories is fine and it might be okay, but it's the pervasiveness of these behaviors. Calling in your own prescriptions, using street drugs with them, these are addictive behaviors. That's not good, that's not acceptable, but tolerance is. Now, another group that we use sometimes that's off the beaten path for severe headaches is stimulants. Adderall, Ritalin. Some people with headaches, many people are actually very, very tired. That's their main problem outside of the headache pain. And stimulants can actually help the tiredness, sometimes help the concentration and the pain. Stimulants such as Adderall, Ritalin are the 2 main classes, and then there's variations on these. Adderall has a newer one called Vyvanse that people like, but it's branded and more expensive. Stimulants can help concentration, energy, and they can help the pain. Sometimes pain is much better on these. Sometimes they only help concentration and energy, but not the pain. So then we have to decide, is it helpful enough for the person's quality of life, even though it's not helping the headaches? But we think in a small select group of patients, sometimes stimulants are pretty good. MAO inhibitors are another category, and they used to be used a lot. MAO inhibitors are strong. They're called monoamine oxidase inhibitors, MAOIs. MAO inhibitors are a strong antidepressant category that we used to use a lot in the 1980s. And then when SSRIs such as Prozac and Zoloft came about, their use went way down. There's a newer one called the NSAM patch. It's branded and somewhat expensive, but NSAM is safer. People put a patch on for 1 day, 24 hours, and it has much less of the side effects of the older MAOs. It doesn't work quite as well, but people don't have to watch their diet quite as much as the older ones. These are actually safer drugs than used to be talked about, and for a select group of headache patients, particularly with difficult depression, MAO inhibitors can be terrific. So we think about them more as time goes on. Now, another option, as far as a miscellaneous option, I've gone over the main categories. I'll mention a couple other options for treating refractory patients. Methylergonavine or Methergine is sometimes used for a few weeks or a few months. It's related to the old ergotamines. It's used for other conditions in medicine. It's become expensive and difficult to always find, but sometimes Methergine helps more than our other treatments, at least for a period of time. There's an Alzheimer's memory drug called memantine or Namenda that sometimes can help if people are in their 60s or 70s with mild memory problems or what we call mild cognitive impairment, MCI, where they're pre-Alzheimer's or they're just having more memory problems than their age would indicate. Sometimes Namenda is a good option because it can help the headaches also. Sometimes it helps headaches in younger people, and we'll use Namenda even in ages 20, 30, 40, 50 because it's relatively mild, we don't get much side effects, and it's a very safe drug. Other miscellaneous drugs, muscle relaxants, sometimes we'll use non-addicting muscle relaxants. I don't like to use the addicting ones like Valium or Soma nearly as much, but we'll use ones such as orphenadrine, which is Norflex, Robaxin, Scalexin. These are non-addicting muscle relaxants that can help. Half the people with headaches have neck pain. So we'll go after the neck pain, sometimes with muscle relaxants. Most of our medicines help headaches better than neck pain. So neck pain, we use physical therapy, we'll do exercises at home, Pilates, yoga, etc., etc. But muscle relaxants do have a role, and some people respond well to them. There's a device that's come on the market called TMS, transcranial magnetic stimulation, and it's a little unit that people put on the back of their head for 10 seconds. They get a pulse or two of a fairly strong magnetic wave, and this has some utility, some usefulness in some people with migraines. I'm using it and will be using it more as needed, once or twice a week. It is being used as a daily remedy to prevent headaches right now, but I'm not sure that we have any long-term data or long-term safety. So I'm waiting before we start to use TMS on a daily basis. But there's been many studies on it for at least 9 years. It's been very well studied. It is FDA indicated as far as the device, although there's a big difference between FDA indication for a drug versus a device. It's easier for devices, but TMS, I think, will have a role. Ketamine is an interesting compound. The FDA is fast-tracking a ketamine nasal spray for severe depression. For over a year, we've been using ketamine nasal spray in the office here and there, and I find it fairly effective for refractory depression. That's its main use. There's been a number of studies on it for chronic headaches, but more for depression. But some people's headaches do respond to ketamine, but it is addicting. I think the intravenous ketamine that's used quite often has a lot of side effects, such as hallucinations. We have much less than the nasal spray, but a big downside is you can't do this at home. Very few doctors, there's a few around the country who will give home ketamine, but pretty much it has to be in a doctor's office. But I mention it because it's one of the refractory therapies that sometimes does help, that's becoming more and more popular around the country. There's this electrical neurostimulation that people use where a wire is implanted either in the back of the head and or the front, usually in the back. And for some people this does help. It takes a very skilled surgeon. The techniques and hardware have come along greatly. I'm more excited about this one from this company ATI, where they implanted in the SPG, because there's no leads and wires that need another surgery 6 or 9 months later. But neurostimulation does help some people. It is a problem because of the cost, and at least half the people don't like it or need resurgery, or there's an infection or something. But occasionally it is useful. There's this migraine surgery that people have talked about and written about. There's migraine surgery centers. I don't think that we have studies showing that this works, and in my experience, which is anecdotal, it's not studies, but I have not seen good results from migraine surgery. I would not recommend it at this time. Similarly, surgery on the septum, nasal surgery, there are a few patients who do well with this if they have a rare condition called contact points in the nose that we can demonstrate. But usually we try to avoid doing invasive things. We try to avoid sinus surgery unless people are having repeated infections. We try to avoid surgery on the septum to fix that if the goal is to help headaches, because it doesn't usually. And similarly, we try to avoid surgery on the neck. It can help neck symptoms if people have pain and numbness down the arm. That's what we call pinched nerve symptoms or radicular symptoms. But if we're looking at it to help headaches, we try to avoid it. And finally, what's coming probably in 2 years are CGRP medications, injections that might counteract CGRP, which is an inflammatory neuroimmune compound. 4 companies are in advanced phase 3 testing. The results look pretty good, at least in earlier stages for all 4 companies. The one thing we don't know with CGRP antagonists or the shots, long-term safety, because they just haven't been out. The other thing is the effectiveness. If a remedy like a shot once a month reduces headaches 1 day a month, is that really going to be worth it? There are going to be people, though, where they reduce the headaches by 5 to 15 days a month, and then that's worth it. Well, I think I'll end here. We're going to be posting other lectures on our YouTube channel on various aspects of headache. Thank you.